Bonjour. Bon matin. I apologize in advance for not being able to address you in French. I studied French in college, as many of us did in the US, and I am miserable at it, unfortunately. So I apologize for putting you to the inconvenience of listening to this talk in something other than your native language. And I do want to thank the interpreters in the back. You have been wonderful, and it's because of you that I've been able to follow the proceedings of this conference. I've learned a great deal about what you're doing here in Canada, what the challenges are, and about some of the similarities and some of the differences between the United States situation and the situation here in Canada. So thank you, interpreters. You are really remarkable. To begin with, there are some significant differences between the situation in the US and here in Canada, one of which is that conversations and policies around linguistic access are inextricably woven with issues around race and immigration status in the US. That makes the conversation very complicated because, as you know, I'm sure, the issues of race and racism in the US are profound, deeply rooted in our culture, very difficult to manage, and extraordinarily difficult to even have conversations about. And so every conversation that we have in the US around linguistic access almost inevitably ends up in a lack of conversation about race and racism. So I want to mention that right from the beginning because it has required us to make some political U-turns from time to time. In the US, there were several issues that kind of prompted more concern around this issue of linguistic access. One was change in immigration laws. In 1969, the US passed a new and radical immigration policy that removed preferences for immigration from Europe. Up until that point, the 200 years of our history, Europe had been the preferred immigration source. It was very easy to immigrate from any nation in Europe. However, most of the European immigrants at least had some familiarity with each other's cultures because Europe is quite compact and shares this common history that goes back thousands of years. And the European immigrants were all white. Beginning in 1969, that preference was removed, and American immigration was given to every nation across the globe, and the immigration visas were based on the population of that nation. And since then, we have had an extraordinary wave of immigration that is truly global in scope, absolutely global, multicultural, multiracial, multilingual. This has changed the landscape of the United States in ways that many people are not very comfortable with. It used to be that immigrants came to the United States to the coast and kind of dispersed from the coast to the interior. And it used to be that the immigrants who came to the United States from countries, non-white countries, non-European countries, pretty much stayed on the coast. And so we have the mythology in the US, for example, of there being a Chinatown in every large city on the coast. That's no longer true. In the early 70s, with the fall of Saigon in the Vietnam War, there was a plan to bring into the country many of the South Vietnamese refugees. And the mayors of the coastal cities rose up in arms and said, basically, we've got enough immigrants, we can't take another large wave, send them someplace else. This was not what I would call a sterling moment in US history, one of our many lapses. But it did mean that the plan that evolved was to send the new immigrants into the interior of the US. And so for the first time in our history, the cities and towns of the interior of the US, the Midwest, the Southwest, became home to an incredibly diverse community of newcomers to the US. That has changed the face of our nation in ways that we are still trying to accommodate to. It is part of the undercurrent that I'm sure you've noticed in our political rhetoric around immigration reform. It has now become a hot button topic because there is literally no mid-size or large city in the US that does not have a substantial population of people of color who speak different languages, bear different cultures, and are integrating themselves into the United States culture as every other wave of immigrants has done. But that's part of our background. We've also had increasingly a body of literature that's emerged in the professional research. I remember in the late 60s and early 70s, people actually saying, well, we have no proof that there are any problems. Duh. We now have tons of proof. Also, at around the same time in the early 70s, there was a rise in grassroots advocacy that has also changed how policies get made. Much before that period of time, policies were made by government insiders and professionals. Increasingly now, policies are driven by grassroots advocacy. And the grassroots advocacy has become quite a powerful force. And it's a very diverse force. Everything from mothers of autistic children to AARP, which is the Association of Retired Persons that represents people over 50. I mean, all of these very large, very powerful voices for change. We have also, in the 70s and into the early 80s, introduced quality measurement and patient satisfaction measurements into the routine business of doing healthcare. Before that time, quality measurement was a voluntary activity that hospitals could undertake. The states required some form of quality reporting, generally in the area of unexpected deaths or infection rates, for example, but it wasn't particularly robust, and it was not designed to progressively improve services. It was designed to meet regulatory standards. Beginning with the HMO Act of 1969, those quality improvement measures now became routine and have transferred from the old-fashioned HMOs into healthcare broadly. So now every hospital, every large healthcare organization has to collect quality information and demonstrate improvement over certain indicators over time. That has also provided a grounding for what we're doing now. New studies have documented barriers that you are all aware of. There was a big study done by the Kellogg Foundation that was a telephonic study, a random survey, that asked people of different backgrounds whether they had difficulty understanding their physicians. It was not surprising that those of Chinese descent and those of Latino descent had the most difficulty understanding their provider. However, what was surprising was that 60% of African Americans also had difficulty understanding their providers, and nearly 30% of white Americans reported having difficulty. Now, the African Americans and the white Americans all were native English speakers, so there's no question of a linguistic barrier here. There was something else at play. And I'm going to refer back to that study later because we've actually been able to use that study to build a business case for why improving linguistic access benefits everyone. We also have been able to document for the first time lack of trust in the healthcare system. Those of us who grew up in communities of color knew all along that there was a profound lack of trust in the healthcare system for a variety of reasons, but providers refused to believe it because they worked in the system. Beginning in 1998 and extending through to 2000, the US federal government, under the auspices of the Office of Minority Health, developed the CLAS standards. CLAS is an acronym for culturally and linguistically appropriate services. One of the powerful things about the CLAS standards was that they were developed with amazingly broad input. They talk to absolutely everyone: advocacy groups, professional groups, hospital organizations, insurance organizations. They really did a wonderful job of reaching out and getting the broad-based input. And they also did something that we rarely do in the United States. They reached across the aisles to people who absolutely disagreed with this initiative, saw no reason for it, wouldn't support it, and they solicited their input as well, which I think was a very canny move. These standards were summarized into 14 standards, and it took 2 years, and if we had to do this today, we probably couldn't afford that process. The standards evolved into 3 themes. These standards can be found in their complete edition on the Office of Minority Health website, and there's also a longer edition that includes the commentary, pro and con, for all the standards, if you care to read that. It's interesting reading. Might put you to sleep, but. The first theme is culturally competent care, effective, understandable, and respectful care, recruitment, retention, and promotion of a diverse staff and leadership. Even today, when you look at almost every healthcare organization across the country, you will see that at the bottom of the staff, receptionists, building services, facilities, it's very diverse, ethnically, racially, linguistically, and I think my mic just cut out on me. Okay. As you go up through the hierarchy, however, it gets whiter and whiter, and at the top of the house, it is nearly all white. For years, I've been the highest ranking person of color in my company, and I'm not happy about that. But I recently got company. We hired a vice president. I'm very happy. But this is common. This is the norm in the US. The only place where it differs is in our community health organizations, where you will see more diversity at the top of the house. But even there, it's not as robust as we would like to see it. So this issue of recruitment, retention, and promotion of people of color and people of diverse linguistic backgrounds is a really critical one for us. Ongoing education, training, and culturally linguistic appropriate care for all staff. This is something that healthcare organizations are struggling with. It is expensive, and there are many mandates in the US around training for staff, everything from training for infectious diseases to sexual harassment. And it's a real challenge for organizations to figure out how to provide this training in a cost-effective way. Theme 2 are the linguistic access standards. Oh, I'm sorry, I pressed the wrong button. There we go. Linguistic access standards speak to the issue of bilingual staff and interpreter services, verbal and written notices to patients in their preferred languages about their right to receive language access services, and patient-related materials and signage in common languages in the community. This includes, for example, patient education materials, discharge materials, any kind of written consent, like informed consent materials. We are doing a pretty poor job with that standard still. And the last set of themes is around organizational support for cultural competence. A written strategic plan, initial and ongoing organizational self-assessment of class-related articles and materials and activities, data collection on patients' race, ethnicity, and language preferences that should be collected in health records and integrated into medical information systems. This has been a huge lift, and it is still problematic across much of the US. You can write in a patient's medical record a lot of information about their ethnicity, their linguistic access needs, their literacy needs, and 7 visits later, that information is pretty much buried, and only a graduate student will recover it. One of the things that the federal government has done is provide funding to incentivize organizations to make that transfer to electronic medical records. And I understand that you're having the same issue here in Canada. It is expensive, it's a heavy lift, It involves not just the technical aspect, but also training the staff to use these systems and organizationally figuring out how you want to use these systems. It's a big lift. And my experience with my clinician colleagues has been mostly that they get very cranky around it. I don't know if you're having that experience here. I would imagine so. The federal government, until after World War II, the federal government in the United States was not a major player in healthcare. However, after World War II, with the establishment of the Veterans Administration, that became the first big footprint that the federal government placed in healthcare. We had a public health service, we had a national public health service, we had a health department at the federal level, but most of the activity around health was run by the states. The VA, the Veterans Administration system, became the first big initiative by the federal government, and it was followed in the 60s by Medicaid and Medicare. Those three activities have now made the federal government one of the biggest payers of healthcare in the US, and also the elephant in the room around any conversations about healthcare. The federal government pays something like 40 cents on every healthcare dollar that's spent in the US, and that's a big percentage. But culturally, that's fairly new. The federal government got behind the CLAS standards. Now, the CLAS standards were generated by the Clinton administration, and they were called standards. The intention was that they would be creating this series of standards that would be embedded in everything that we did. When the Bush administration came in, George the Younger, I hope you don't mind that I called him that. Thank you. When the Bush administration came in, they softened the language from standards to guidelines, but they did not abandon the CLAS standards. In the industry, we still refer to them as standards, but the official language continues to be guidelines. The Obama administration has not monkeyed much with the language. They have continued to look for ways to continue implementation. The government has taken an active role. First of all, there isn't a typographical error in this slide. That should be Title VI, not Title 11. Title VI in the US is the federal anti-discrimination law that I'll show you later. And they've used this law as a bedrock legal foundation for the CLAS standards to say that not doing these things results in discrimination in healthcare. Doing these things helps you, the hospital, avoid being tagged with discrimination. And there have been lawsuits. There was a lawsuit 4 years ago in New Hampshire brought by the deaf and hard of hearing, and they actually used the CLAS standards as part of their legal rationale, saying that they were not receiving affordable and respectful care, and they won the lawsuit. The federal government cannot initiate any such suit, but what they can do is bring in the monitoring after the suit has been determined. And so they send in federal monitors to look into the hospital and see, what are you doing to address these issues? Nobody wants the federal monitors on your back. It's expensive, because now you have to dedicate a staff to following the monitors around, getting the records that they want. Nobody wants that. They've also provided substantial funding for technical assistance and for training. I was one of those trainers. I spent a number of years doing consultation and training across the country on behalf of the federal government. They've funded a lot of research, and they're funding demonstration projects. They have also funded offices of minority health in all 50 states. Now, the states have agreed to have these offices basically because the feds are paying for them. They're not necessarily happy to have these offices. And the offices, the reach of the office varies from state to state quite significantly. This is the federal Title VI anti-discrimination mandate. And this is where legally we come back to. There is no legal force behind the CLAS standards, but there is legal force behind this mandate. The state governments, who manage most of the local health care, as I understand is true here as well, have provided technical assistance and training through their public health departments and through other channels. Now, the states vary enormously in how active they are in this. In some of the states, the offices of minority health are voices crying in the wilderness. In other states, we're more fortunate, for example, in Massachusetts and New York, to have fairly robust programs. But the offices do exist. The other thing that states are doing, some states, again, my own state of Massachusetts being one, is that the states started looking at vendor contracts, because that's one of the things you can control without legislative process. You don't have to go to the legislator to ask permission to create your criteria for vendors. And so we began embedding CLAS language into vendor contracts. So if you are selling, for example, sheets and towels, you might have to let us know that you have bilingual, bicultural staff. That's a far-fetched example, but it's an example of how you can use vendor contracts to promote linguistic issues. And a few states, Massachusetts being one, there are actually only 4 states in the country so far that have passed any laws around linguistic access. Massachusetts passed in 1993 the Emergency Room Interpreter Bill. Now, technically, the bill only covers emergency rooms and walk-in mental health emergency systems. However, we've been able to leverage that bill to bully the hospitals into building robust interpreter systems throughout their hospital. And it has been an act of basically the state kind of bullying the hospitals and saying, you gotta do this or we're gonna find something to pick at you about. It has worked in Massachusetts. The other states that have some form of interpretation law or linguistic access law are California, Oregon, and Minnesota. Other states have not chosen to put this in legislation, which is why, again, these other kinds of strategies have been so important. I wish I could read my own slides in French. We've also worked with regulation, because again, regulation does not necessarily have to go through the legislative process. You can deal with regulation within the house of the Department of Mental Health or the Department of Health Care or Social Services, for example. The Center for Medicaid and Medicare Services has taken this route as a way to push the implementation of CLAS, and they have embedded the linguistic access standards into every contract. Now, this is very powerful because there's not a single hospital in the country that can afford to say no to Medicare and Medicare dollars. They have to say yes. It's too big a funding stream to turn your back on. And so it has been very effective strategy for moving these ahead. We've also seen policy changes at both the local, state, and federal level, and those have been very quiet behind the scenes, sort of trying to integrate these standards. The other powerful initiative that we've had is the Joint Commission for the Accreditation of Healthcare Organizations, commonly called the Joint Commission in the US, accredits hospitals. Joint Commission accreditation is voluntary. Hospitals do not have to seek it. However, many insurance companies, ours among them, will not do business with a hospital that's not Joint Commission accredited. So that's money in your pocket, and that has driven hospitals to get the Joint Commission acquisition. The other body has been the National Committee for Quality Assurance, NCQA. They accredit health plans. And again, this is not mandatory accreditation. However, many large employers will not purchase insurance from an organization that is not NCQA accredited. These two things have done more to integrate CLAS standards across the country than any other strategy. And they are taking a gradual and a developmental approach. They have been implementing each pass. The Joint Commission accreditation is every second year. NCQA, I think, is every third year. And so each time they come around, they add a little bit more, a little bit more, a little bit more. And it's very gradual, but it really is pushing the systems to integrate these standards, or pieces of the standards. Private foundations have also been major players here. The large foundations, the Kellogg Family Foundation, the California Endowment, the Robert Wood Johnson Foundation have been major players in this area, funding studies, funding research, funding pilot programs, demonstrating best practices, really helping to flesh out what does it look like when you build the class standards correctly. Because we don't know, we're starting from ground zero. So these projects have been very helpful at kind of giving organizations a roadmap. This is what it could look like. State governments have been providing technical assistance and also embedding class language and standards. I think that is a repeat slide, isn't it? Sorry. Harvard Pilgrim Healthcare, we are a regional health insurance plan. I'm proud to say that we are the #1 private, not-for-profit, no, we are the #1 insurance plan in the US for 9 consecutive years. No other health plan has ever done that. And part of the way we did it is that we focus on service, and we first focus on the patient and member experience. We began working on cultural and linguistic health issues back in the early 90s when we formed a Office of Diversity. And we created training programs for medical interpreters because nobody knew how to train an interpreter. We had a lot of bilingual staff that were being pressed into service as interpreters. They didn't know what they were doing. The clinicians didn't know what they were doing. And we got some awful results out of that. So we had to figure out what are the basic skills that an interpreter should have. We designed a 42-hour program that used bilingual, bicultural coaches so that the training was not in English, so we could actually assess the competency in the target language at the end of the training. We created training for clinicians, and one of the approaches that we took was to make sure that any training we designed for clinicians was designed by clinicians from that specialty. So we co-designed with content experts like myself and people who were from that discipline to make sure that the training fit the mores, the culture of that discipline. We also trained clinicians to present the training. We learned very early you cannot put a social worker in front of a room full of physicians and get much credibility. You have to put physicians in front of a room of physicians, dentists in front of a room of dentists. So that meant we had to go out and find professionals who were interested in doing this and had some content expertise and train them how to do this kind of training. One of the things we learned that was most critical was that it's very important to train people in facilitation skills. This is not the kind of material that can be trained in a didactic way. What happens when you present it didactically, you put slides on the wall, talking head in front of the room, lecture about these things, people have the resistant argument in their head. They're sitting there the entire time resisting, and they walk out of the room resisting. You have to create a safe space where people can have conversations with one another. And the constant feedback we have received from the professionals trained is they've never before had an opportunity to sit in a room with other doctors and freely and openly and safely discuss these issues. That has been a powerful, powerful part of the success of our training programs. We now are Culture Insight. We provide consultation and training. We help develop policy when called on. We work with state, municipal agencies, and with universities and medical schools. We've been trying to swim upstream. I'm kind of tired of trying to retrain professionals after they've been working for 20 years. I'm trying to figure out how do we train them right the first time. What we've learned, one size does not fit all. Each organization has its own culture, its own history, its own style, and it has to evolve its own solutions. Trying to impose a one-size-fits-all is doomed to failure. Leadership buy-in is critical, but not sufficient. You have to have leadership buy-in to get anywhere, but leadership buy-in alone is not sufficient. You must have some degree of readiness and capacity in the organization. So sometimes you have to back up a step and work to build that readiness and capacity before you start working to implement new policies. We learned that organizations need to have something at stake. And this is where the business case comes in. You have to develop a case for what you're trying to do that's connected to the organization's bottom line. Remember that study I referred to at the top of my talk, the people who had trouble understanding their physician? We've used that as a business case to tie linguistic access to health literacy and to make the case that linguistic access is part of improving patient providers' communication, and that will save the hospital money in the long run. That we can demonstrate. Lower emergency room costs, fewer repeat admissions that could be avoided by better communication. We can show that. We've learned that you have to use a broad framework of culture. Here you are concerned predominantly today with the Francophone populations in Canada. However, you also have other linguistic needs in other communities. So you want to try to broaden that lens, particularly when you talk to hospitals that have small Francophone populations, and remind them that among their English-speaking patients, they have people who would benefit by some of the things that will also help the Francophone population. Make that broad case. It's important to take a developmental perspective to understand that organizations must follow a growth track. They can't just take a big leap, and they will resist a big leap. Big leaps don't work. Help organizations make the small steps and steady progress, and be there for them in the long run. Don't chastise them when they stop at step 2. Simply say, when you're ready for step 3, call us. We'll be right there. That works. And it's critical to be flexible and adaptable. Things change constantly. Your economic situation changes, the organization changes, leadership changes, the patient base changes, things change. So it's very important not to get wedded to any one structural approach. Think creatively, be ready to change at a moment's notice. We've been at this for 20 years. We've changed our approach repeatedly, and we have changed it yet again. We are now working not with individual organizations, but collaborations of organizations. We are offering our services. I'm no longer going out there trying to find organizations who want to do this. We are now asking organizations to come to us. So that helps us weed out organizations that are not ready or interested. We're not wasting our resources. We're a tiny foundation. You know, we have an annual budget of about $3 million. That's not a lot of money for a foundation. We are also requiring organizations that are interested in getting our free technical assistance and training, which is quite outstanding, if I may say so. We require them to collaborate with other organizations and to collaborate with community-based organizations. We will not even look at a proposal that doesn't have those factors in it. So we're trying to experiment to see what happens when we work in this way. We're looking at working with place-based work. We want to be able to, with this new approach, do a better job of measuring our impact. We want to see what happens when we focus on a strategy or a set of strategies that are specifically designed for a particular place and region, not designed necessarily to be promulgated across a wider constituency. We're looking at the collaborations to disseminate information, and we are requiring them as part of their proposal to have a visibility plan. How are they going to talk about what they're doing to other organizations? And we're building sustainability through training and through mentoring. The mentoring is very, very important. Just because you train people is not sufficient. You have to have resources there to check in with them 4 months down the road, 6 months down the road, a year later. How are you doing? What do you need now? And really mentor them so that the skills stick. And we've had great luck with that, and we're really trying to build sustainability. This work is very expensive for organizations. Don't underestimate that. And we've worked very hard to find models that use internal staff, build capacity internally, and can be sustainable over the long haul and reduce costs to the organization of doing this work. I think that this is the approach that has more promise for the future, especially in the economic position we find ourselves in. And we are moving beyond one organization at a time and trying to influence groups of organizations at the same time. So that's what we're trying now. It's a grand experiment. It's a journey, and we've been on it for a long time. We're on it, and it doesn't end. It never ends because everything changes. Thank you very much.
Thank you very much, Dr. Dowd. Bonjour tout le monde. Quel plaisir d'être ici parmi vous aujourd'hui. Je suis très désolée de ne pas avoir pu participer aux activités de mercredi et jeudi et surtout de ne pas avoir pu swinguer avec vous hier soir. J'entends dire que c'était pas mal amusant. C'est un grand plaisir de vous parler aujourd'hui sur l'avancement de l'imputabilité sociale par l'entremise des recommandations du projet